the supporters of the organization, and we're very pleased that you were able to join us tonight. And this is a special session of Meet a Scientist in that we have our new scientific director joining us this evening to give us an update on his work and vision for the Institute. Before I introduce Dr. Van Herrath, I wanted to just take a moment for one additional housekeeping item, and that is about really the fact that Dr. Van Herrath will present for about 15 minutes, and then we'll move into Q&A and discussion. So we've carved out a good amount of time for questions and for discussion. So we'll look forward to that. Without further ado, I'd like to take a moment to introduce Dr. Van Herrath. Matthias is one of the world's leading experts in diabetes. And said he is the new scientific director of the DRI. And he also holds the Stacy Joy Goodman Chair at the University of Miami Miller School of Medicine. Dr. Van Herrath joined the DRI after serving as professor at the La Jolla Institute for Immunology in San Diego. He brings more than 25 years of dedicated research into diabetes and was twice ranked as the #1 juvenile diabetes expert in by Expertscape. Dr. Van Herrath has been the recipient of the American Diabetes Association's Outstanding Scientific Achievement Award in 2008, the German Diabetes Society's Langerhans Award in 2014, and received a Lifetime Achievement Award from the Network for Pancreatic Organ Donors with Diabetes in 2016. He is leading the DRI's mission to conduct and accelerate research to delay, prevent, and ultimately cure type 1 diabetes. It's my pleasure to introduce Dr. Van Herrath.
Well, thank you, Michael. I'm here with great happiness to have joined the DRI, and you see that this works. Share my screen. Yep. And also with humility in many ways, because this is a fantastic place, and we will talk about this in the next 15 minutes, what it's really so super cool about the DRI. And I stand here with great gratitude because, as you will see and go to our scientific strategy and what is new in the quest for a cure for type 1 diabetes, the foundation is absolutely instrumental for this. And I should say all we do, all I have been wanting to do in my career is really for the patients. That's my focus. Because of that, during my career, I shifted more and more from initially basic research into more clinically applied research, developing combination therapies, shifting to understand the human disease better, and also joining a pharma company to then conduct appropriate trials to bring things that are promising to the clinic. So this has been sort of one continuous quest. You should feel free, you can always interrupt me and ask questions, and we can take the questions at the end, and you can also put the questions into the chat. Now, the Diabetes Research Institute, when I was approached, I didn't have any dire need to make a move. But there came this opportunity. And so you can ask, why is the DRI so special? Why does it stand out probably as the one diabetes research institute pretty much in the world that is exceptional, and certainly in the United States? And there's a couple of factors I think I want to put right at the beginning. It has a culture only of passion, but also of collaboration. And that might sound in a way trivial. Some of you might think, well, of course, that's what we should be doing. But that's not so much the norm often in academic enterprises. In this culture of collaboration and passion that you see at the DRI is also mirroring the same culture at the University of Miami. I didn't know this when I came interview and started meeting people. It is really unique, and it's a unique mindset. And it's, for me, because I like collaboration, I feel we need this to bring things to the finishing line. It's because of that a very unique place and a very unique situation in academic research, for sure. Then what you can also see, and that's also very special, it mingles disciplines. We not only concentrate on the beta cell or the islets, not only we will do more on the immune system, but there's also very strong groups working on devices and trying to protect with devices the islets from the immune system. And certainly last but not least, the orientation towards patients and the clinic. So you bring everything together really to have a comprehensive situation where you can also do clinical research and with that bring things better to the finishing line. And you can already see how this fits together. If you want to bridge between disciplines, which is not something you have to do in academia, you need the mindset and the passion really to do it. The investigators have very strong international records. That's one thing I kind of knew, because you look the other colleagues up, and of course there were strong ties before, and I knew many of the investigators. But we have a very, very good group of investigators at the DRI, junior up to senior, so much energy and so many new ideas, as it often is. Probably even the new ideas more weighted towards the more junior people. That's how that goes in science, and that's how it should be. It is really very special. And of course, it is patient-centric with that. So it's a very unique place. I haven't quite seen any place like this ever in the US, for sure. And we have been part of the BRAIN Coalition. That was a coalition of many diabetes centers. And these were good centers. And the DRI, I call it often a hidden jewel, because it wasn't there, but it should have probably been the principle of the whole situation. It is really a very, very cool place. So where do we stand in the field in terms of bringing things to patients to the clinic? I sometimes say that I stand on the shoulders of giants in various ways at the DRI and at other places. This is now a very exciting time for really getting closer to being able to envision how curing or completely preventing type 1 might come to fruition. One thing is that we have now, as many of you are aware, a proof of concept from the company Vertex. Vertex has brought stem cell-derived islets to the clinic. And that is a major achievement. You can say, but, and that's in the blue box down there, we still need to work on the immune suppression, and I explain it in a minute. But that by itself, that we have now a vision how the supply could be solved, is a very, very important proof of concept. When it comes to the immunology, just very recently, the first company, Provention Bio, now bought by Sanofi, has been bringing the first drug, anti-CD3, it's called TZIELD, to the clinic as an anti-T cell drug, and it can delay diabetes by average of 2.5 years. Beforehand, these two things were just hypotheses that this should be happening, and maybe it was true or maybe not. Now we have the foot in the door. We actually know that these things can work and be feasible. That brings us in a very good position to tackle what I call the finite frontier, to bring things in a general sense applicable to most, if not all, type 1 patients. And that's what we need to deal with, is to make immune modulation, or keeping the immune system from seeing the beta cells, attacking the beta cells. We need to make that generally tolerable and applicable. And maybe it sounds to some of you an easy task, but this is not easy. When you consider how things have advanced in oncology, of course, you have drugs that can kill cancer cells, but they can also kill the whole patient. You have immune suppressive drugs that can completely cure type 1 diabetes. You can do a bone marrow transplant, and it is extremely risky, and you will lose patients over that. So these things are conceptually good, but they're alone not feasible. And we need to circumvent that, and I will explain it a bit in the next couple of slides. We need to combine things and make sure we can suppress or not have side effects. And actually, as a point taken, when you look at oncology, the development for many cancers has been this fine-tuning, that you use different drugs, but you spread the side effects, and all of a sudden, you can have amazing breakthroughs, for example, in leukemias. And I worked clinically in oncology in the late 80s. We had a huge celebration for a survivor of leukemia, which now many of us would assume is more the norm. Back then, it was the exception. Every patient was lost. So that shows you how powerful this fine-tuning and building better immune therapies can be. And that's what the DRI has to do. Now, if I say fine-tuning, finding a balance, finding a way to better shield beta cells from the immune system, you can say, how hard can this be? You just need to find the right factors. Fine-tuning is not so easy, and finding priorities is not so easy. And definitely in this field where trials are cumbersome and long, it's not going to happen by just putting one drug in the clinic and waiting for the outcome. 5 years in the worst case, or longer, and then another trial, wait for the outcome, 5 years, develop things, and so forth. You lose every time you do this. You can lose as much as a decade to just get one answer. So we need to prioritize before we run the trials. We have to have a strategy of ranking things or traffic lighting things, so we are in a better position to pull the trigger on things that should then go in an informed way into the clinic, and then be used in the large outcome trials that would ultimately give you the desired cure. So that's something we will do with new technologies, organoids, new platforms that we can use to prioritize things, and maybe in some cases, biomarkers coupled with AI. It is fundamentally important. I always give the analogies like having pieces and knowing you need wings in the tail and the fuel to fly an airplane. But then this becomes a sweet spot fine-tuning exercise, because the reason we have planes flying so safely right now is that they operate in a very clearly defined space. It's not a free-for-all, and certainly not an easy type of a task. I wanted to give you some glimpses of who is attacking the beta cells. Here, this is a movie. We were the first ones to do live imaging. This is in the mouse. The little green guys are the cells that kill the big green blobs, which are the islets. You can see in the pancreas, once you get the cells in there, this is like a full-scale army invasion. They go wherever they want, and they find the islets, and then they murder the beta cells, so to speak. And we have to control these cells. Now you say, well, is this complicated? It is complicated because the type of cells that these cells are, from what we know in humans, they are CD8 cells mostly, and they are often of a CD8 memory type of cell. These are the same cells that all of us have to keep us infection-free, defend us from bad COVID, for example, and keep us cancer-free. So we can just eliminate all these cells. All hell, and that's the balance of immunotherapy, all hell will break loose if you do that. So that gives you an impression of the tasks that we need to accomplish. The way this goes is also, when you look at the loss of the beta cells, we have a phase prior to clinical diagnosis, and then loss of beta cell function leading to clinical diagnosis. In this phase, when you can still prevent things, which is in a similar way, the phase that you want to protect transplanted islets in the long term, in this phase, you need to have a therapy that covers the whole time with all the flares. You can just reset the system. So it's sort of like therapy that you stay on, like an anti-high blood pressure medication. and it needs to be tolerable. Otherwise, nobody is going to stay on the therapy. And then this here happens and the beta cells are being lost. Or you have to put new beta cells in, but then you reset the system to here and you still have to maintain that immune pace when you put new islets in by and large. I also wanted to show you and give an impression how we have now started to reflect what happens in the human pancreas in what they call organoids in the reagent tubes. There are 3D organoids of mini islets, one per well, sort of to make things replicable. And in the right-hand side, you see that we can have these islets being eaten up by those aggressive lymphocytes, and they can either be cells that recognize organs from other people, like it might be an islet transplantation, or autoimmune cells. So these cells we need to deal with, but ideally locally, and ideally by camouflaging the islets, or locally when we put them back into patients, suppressing the immune system from reaching them by putting smart cells in their vicinity, or together with an engineered device and so forth. That will be our exercise to combine these things. So these are priorities that we will be emphasizing. We will be looking at things that can work locally to protect the beta cells as to not affect the system. We would like to augment beta cells. There's some promising therapies that we would like to test. We would like to camouflage the islets, and we need to better understand human pathology, immunology, and better biomarkers. So these are things that we'll be fostering at the DRI. We couldn't do this without the outstanding scientists, and this is just overview of many faces that might be certainly familiar to some of you at work. Not all islets are shaped like a heart, but this is a particularly cool looking one down here. This is the energy of the place, the love and the passion of the place. These are the people that because of DRF, because of you, can be there, can be run their programs, who will be instrumental to bring us the cure. Last words before I close. We have, in addition to what you would call core operations of the Institute, we have some very ambitious things we would like to do. And we call them quantum leaps because also financially, because of their size, you cannot do these type of things within the normal operations of the Institute, but they could move the field a lot. I give you two glimpses, and then I'm going to close. One is that we think that destruction of the pancreas and the reason the immune system sees our islets and beta cells as something it should attack. The short story is the cause is not known. Here is a hypothesis how this could happen. This is a different disease, and it's called vitiligo. You lose the pigment of your skin. And you see the model there. And what is striking when you look at the pictures, this is not only spotty, but it's also symmetric. So now you explain me how a randomly moving around immune cell in the body would make symmetric changes on either side of the body. It could, of course, be the anatomy, but we're looking at skin here. Skin is skin. Then it could be sun exposure, but it's not only sun exposure, unless some weird gloves would be into play here. So to make the long story short, we think that innervation and the symmetry that comes out of innervation and innervation of the pancreas is critical in defining whether the organ can be attacked by the immune system. And others and ourselves have shown this, that if you cut certain nerves to the pancreas in mice, then these attacks don't ensue. So that to test this and to bring it to the clinic is a quantum leap, because you need to work with smaller companies that can modulate nerves. You need to understand the basic of innervation of the pancreas better, and you need to then make a product. So these things are not particularly easy, but if they would come to fruition, they could move many things, including type 1 diabetes. And then another quantum leap is to have these combined therapies out of things that we see and develop at the DRI. And the idea here is to combine immune system modulation with protection of beta cells. And all therapies will have side effects, but we want to spread the side effects by we synergize, protect the islets. That's really the concept of building proper combination therapies. And that will have to happen in islet transplantation or stem cell derived islet transplantation, as well as in prevention of the disease. Ultimately, you can envision that, for example, for prevention, you have these drugs, such as drugs that can support beta cells, selective drugs that can keep the immune system at bay, sort of making peacekeeper troops. And these you could give all the time. And then targetedly, immune system modulators, but for a short time. You can have two scenarios then. One is the prevention, where you start with the mild drugs and you give the stronger drugs should you become diabetic. The other scenario is islet replacement. There you give the stronger drugs first because the islets go in, and then you use the milder drugs for maintenance. So these are the concepts we would like to work on. If I don't work on diabetes, which the family sometimes tells me is too much, I love spending time with the family, little and big kids. Sometimes play the violin, actually often play the violin to calm myself down, and sometimes play the guitar, make some noise. This picture was at my wedding, so I made a lot of noise there on the guitar. And I'm ready for questions. So thank you for listening. I think we have a good half hour to take some questions, and I'm going to hit the stop share button, I think.
Thank you, Dr. von Herrath. Great talk. And I suspect it's stoked some questions in the minds of our guests. So why don't we jump into Q&A? Just a little housekeeping. If you have a question, just feel free to raise your hand. We can see you, or you can do it virtually with the little hand raise icon. Alternatively, you can put a question into the chat, and Sarah will be monitoring that and reading them as we receive them. So please don't be shy. We have Dr. von Herrath with us for a little while. And again, thank you, Dr. von Herrath. It was a great talk, and let's hear some questions. Michael.
Thanks, Michael. Dr. von Herrath, thank you. Thanks so much for that and for the context. Just a quick question with regard to quantum leaps. Is that a subjective term when you feel, hey, this is something worth paying attention to kind of thing? Or are there scientific standards for when something qualifies as a quantum leap?
No, these are subjective terms. We actually had many discussions how we best call these bigger projects. It is subjective terms. For something that is a big deal approach that is risky in most cases, that will move the needle tremendously, but where the costs and the organization is complex enough that you cannot do it with a normal institute or university operating budget or a single grant, for example, from NIH or other funders.
Thank you.
It's really what they're there for.
Go ahead, Bob. Check your mute. There we go.
Yep. Thanks, Dr. Herrath. This is just great stuff. I saw you out in Long Island a couple of months ago, actually a year ago, I think, and just great stuff. And I'm very excited about hearing and getting this literature and information out to the public. I'm very dedicated to that, so thank you. A couple of questions on the sweet spot. On the encapsulation area, I know we have to try to protect those cells as we insert them into the body. I know there's been different work being where to put it, oxygen, and a lot of different issues. Where are we today on that encapsulation? I know you guys did a lot on the scaffolding, and I was just curious where we are today on that.
I think there has been exciting movements just recently. And I'm not only talking about the trial from Vertex that also is happening in Miami, where they use no more immunosuppression to test their encapsulation device. And to be fair on that one, we don't know how high the chances are that it's working as an alone standing entity. What I find particularly exciting, what many investigators do at the Institute, and Giacomo, who is on the call, is certainly one of them, is to have a device-specific or capsule-specific local suppression, a defense system, so that invading immune cells don't have a good time arriving there, and to make these devices their home, so to speak. And that can either be done to cells that might be live longer and have a way of keeping the area peaceful, so to speak, or it can be done to attached molecules that will give invading cells sort of one over the head so they don't stay there, so to speak. I know you're using a lot of figuratives here, but that local suppression is very exciting. The other area I find exciting, some of them do it with printing. We have to see whether that's necessary. There's also other ways to do it, to have maybe islets engulfed and wrapped in their own little skins, so they are a bit less accessible to invading immune cells, so at least you don't have cell-cell contact. Immune system tends to get very excited when you have cells contacting directly each other. They have, even when they kill each other, they have a stay time, they crawl over each other, and when they're sure enough, they deliver the lethal stroke. So if you take this away, then the only thing that can damage an islet is maybe something that comes from the cell that's in the vicinity, but triggering the cell would not occur to the islet itself. I find that pretty exciting. Of course, the challenges are, look, it has to all be done to keep oxygen supply and the site properly working, and that's not a little order, because the islets, when we look at them pathologically in the mouse, in humans, especially in the mouse, you can see it, they have, because we can live image it, right? In humans, it's difficult to live image. They have a lot of vessels. They need a lot of blood because they're so active. So that's something that needs to be solved to keep them happy. And it's a sweet spot balance, because if islets get unhappy or they don't have enough oxygen, once they start dying, and all schmutz that might come from dying islets activates the immune system. Immune system, when it gets too dirty, thinks that it needs to be cleaned up. So that's a fine balance. Once that starts happening, is not good it's the road to perdition to transplanted islets. So
I have one other question, if I may. Also along the lines of the sweet spot, you say that there's a new biological tool, organoids. What is that?
Yeah, I love these organoids. We have worked with them for 6 years, and they are really recreated. And the word is 3D, but it means that they're not flat sitting like cells usually in a region tube on the surface, but they are 3D. They're hanging more like real organs in space, and that seems to behave better than having cells flat on the surface. And I realized the important, there's many companies doing it. We work with a specific one. It's called Insfero, and they are located in Switzerland. And what caught my attention, they were making these organoids from liver to look at drug-induced liver toxicity. That's a general problem. If you develop small molecules or other drugs, if they're liver toxic, that's usually game over. So you want to predict this. You don't want to find out for a variety of reasons, the most being for the patients, but definitely you don't want to find out about this in a trial. And the predictive power of 3D versus 2D flat on the surface was much better. And I thought, whoa, this really makes a difference if we build these little organoids. They might be more realistic than flat systems. You can also image to the whole islet, and you can also work the fluidics that the islets, at least in our case, over a 2 weeks time frame, are pretty happy. And so it gives you a 2-week window to look at things. There are various flavors, and the ones we have used, we make them all the same size because we want reproducibility and replication of our experimental finding. Other people build organoids, for example, from the brain, and have them more freely growing if you want to, for example, understand how a kidney or a brain develops. So there's many ways to have these pieces of our human bodies as single entities in the reagent tube, and then manipulating them. The advantages is faster, it's cheaper, and it's ethically easy because you can do many things to these islet organoids, right?
Thank you very much.
Tom, you have a question.
Could you kindly, in simple terms, explain what the possibilities of prevention bio and the work at Vertex is for those of us who have either had or our children have had diabetes, type 1 diabetes for years?
Yes.
What is the application of what their work and how would it translate to help those who've had it?
So starting with Prevention Bio's drug, this is now licensed for prevention of diabetes, right? So if you had the disease for years, it's not licensed, but I get to this in a second. It's not licensed for that at all. It's to delay the clinical onset of diabetes. They are seeking to achieve also a label extension, so you can give it right after you're diagnosed when there's still beta cells around. Okay, so that's the prevention bio thing, and I'll come back to that in a minute. It is in terms of treatment burden, because you have to have several infusions in I think 10 days. It has still a substantial treatment burden, and to lock in the effect, and I'm sure they're working on it, it should be combined, maybe in some cases given again. So that's the anti-CD3 drug. Earlier, and you can be given when you have antibodies and you become dysglycemic, so pretty late just before clinical diagnosis. If you do it earlier, it would be preferable, in my mind, to have a therapy that has no systemic immunosuppressive burden, where you can stay on for the whole time, as I said before. Okay, whether anti-CD3 can be used, the prevention bio, to reduce the immune system after islet transplantation, there are several papers on that. That I find is a quite interesting thought. Now, the Vertex is different. Vertex had the proof of concept that their stem cell-derived islets can work in patients over a year and longer, but with full immunosuppression. The second trial now worked in operation, and this is relevant if you had the disease for years, because you put new islets back in, right? So their second trial is a trial where they use their devices to protect the stem cell-derived islets. And we have to see, this could be extremely good and solve many problems, or it could not be so good. I certainly think they are charting new territory, and I find it extremely exciting. That is definitely to be said. And so that's how they fit in the field all together. So Vertex is when you had the disease for years, to bring new islets back into the patient. Anti-CD3 prevention is to prevent the disease, and maybe, depending how their label gets extended, also after onset.
So should they, just one follow-up, should we figure out a biological means to reverse type 1 diabetes? Could the work at Prevention Bio then be used to stop the body from reattacking whatever it is we do to it?
Yes. So you could say, and I had it on my slide before, that we are looking for compounds that can regrow beta cells. So you don't have to put them in as a transplant. I find that also very exciting. And there's some compounds that have shown promise in mice and in vitro, so in the reagent tube, but we don't know whether they would work in humans. But the DRI wants to play a role and will play a role in testing some of these compounds. Now, these compounds, if you would regrow beta cells, then you don't need an islet or stem cell transplant, because you regrow the beta cells. And to protect those, it's a very good question, Tom, you could use an anti-CD3. And the anti-CD3 fits in because, in my mind, as a systemic immune modulator, so you would start the therapy with this, so to induce, and then have a maintenance therapy of compounds that are better tolerable that you stay on. In my mind, it's something for the beta cell, like I said, and something that reduces the immune system, but just selectively the cells that attack the beta cells and not the other guys, which I think we are slowly learning how to do that. And that will, of course, is almost like we call them tolerance vaccine. And we have one of them in the clinic right now. There's several others that have been built. You can call them peacekeeper troops or tolerance vaccines. It's pretty interesting, that field altogether. And with that, you would then maintain the newly made beta cells,
right,
or conversely, the ones that you introduce after an islet transplant. You know, there's still many open pieces, but you see what I say? We have the pieces, like this airplane, and we can start putting them together now in a very logical way, transdisciplinary.
thank you.
Other questions? Matthias, I'll ask a question. Kind of stepping back a little bit from the science and kind of focusing a little more on strategy. What are your thoughts on collaboration and the importance of collaboration between an institute like DRI and other important players in this space, industry, other academic research institutes, foundations? Could you just reflect a little bit on collaboration and what you think about when I use that word?
What I think about, I said in the beginning, and it's right to the button, I'm a very collaborative guy. So, and the mindset certainly at UM, as I said, is very good for that. What you're asking, how do we foster collaborations in academia and pharma companies? I think there are many models, and we will foster these, especially in the space where you translate things to the clinic. For example, I had today a very interesting call with a friend of mine who is now at Flagship Pioneer Incubator in Boston. And so these guys have all these platform companies where if you have a new idea, they can help you shepherd this with the right tests to the clinic. So these type of collaborations with entities like this that then make druggable entities that might be ready to be bought by pharma companies, that's very important on one hand side. The other thing that's important is pharma academia collaboration. They're mostly coming about, and the DRI has a ton of them actually, by many investigators, as specific projects where our technologies and know-how at the DRI are perceived in a way that the pharma companies see that as a tremendous value and accelerator and uniqueness. So you want to be that as an academic institute. You want to have that because you want to matter and you want to accelerate the process. And I think we have that thanks to the eminent investigators we have there. Now, collaboration between different academic centers, that can sometimes be a bit challenging, and not because of the DRI mind. Can encounter sometimes some interesting phenotypes and mindsets in the academic enterprise, in my experience of having been there for 35 years in various countries. We have built what is called the BRAIN Coalition. Probably mentioned it before, maybe 15 years ago. And it was the entry criterion to be in a BRAIN Coalition was the people had to have a collaborative mindset, putting others and the greater good before the individual lab. And that type of coalition and the centers, it still exists. I think we want to use in this specific case at the DRI to foster young investigators' careers and maybe have awards for young investigators that transgress, in my vision, that whole coalition, if it can be achieved. And things like that foster really collaboration across boundaries. So you're asking, I answered beyond the DRI and beyond UM. The collaborations locally are very good.
And just a quick follow-up, you referenced young investigators, early career investigators. What are your thoughts on the state of the next generation of clinician scientists, researchers in type 1? how confident are you that they have the resources they need to establish their careers and advance the science in ways that make a difference?
At the DRI, thanks to the DRF Foundation, confident. In general, extremely unconfident. It is a difficult time for young investigators for a variety of reasons. The system is bottlenecked in academic careers. The NIH grants haven't grown since God knows how long, but we have evidently had inflation, just normal inflation. But if you extrapolate it over 20 years, stuff just costs more, evidently for any of us. And NIH grants have been frozen at their level for over a decade, so that's not particularly useful. Reagents are expensive, and at the same time, cost of living for young investigators, as well as the cost of doing research because technology has become better, is more expensive. So this is a relatively toxic spiral to get into the academic enterprise. And I think we have very, very unique situation at the DRI, because we have your funds that can be used to foster young careers, create more sustenance, and buffer the evident valleys that everybody will have, regardless how many grants you write. And I have written over my career hundreds of them, but the trajectory of getting grants for anybody in the academic enterprise is like this, and it has been like this for 30 years. So it's a stressful environment, but you want people to have a right balance, concentrating on research, and of course, writing grants. Nobody says they don't want to write grants, but there has to be a balance. It cannot be, a frantic kerfuffle about the whole matter. And I think the DRI is a very, very unique place for that. So you ask an important question. I think it's good for the DRI. The general enterprise, and some of you will read about this, is in a place where it needs adjustment. Let's put it like this.
Thank you very much.
We are in good shape at the DRI. We are in a good spot. We can weather that. And I of course, I'm very grateful for that.
That's good news. I think Sarah mentioned that we have a question in the chat.
Yes, Anne would like to know that other than donations and fundraising, what we can do to move the science along.
Of course, donations and fundraising and supporting some of the Quantum Leap projects are very important. And even maybe almost like, I sometimes do this with Children International, where you foster a child in a different country who needs support. You can pick your favorite project for a bright idea of a young scientist and follow that along for a year. What else can we do to move the enterprise along? There's a fair amount of advocacy approaches that we have been involved in. For me, more from the farmer's side, together with the JDA.
Looks like we have a frozen screen.
To make them understand what a fundamental problem type 1 diabetes is for the patients. There's still a lot that can be done. And we will certainly do this from the DRI side. That's something that is a good thing to do. Furthermore, there will be ways in some of the Quantum Leap projects where you can have an investment like a venture capital at the same time that you give funds to the academic research and bring both sides together. I think that is, of course, a decent mix. So these are more creative vehicles. And last but not least, there's something to be said that we can advocate better for the regulators. The regulators for type 1 diabetes, they have been too tight-lipped. We're doing some of this, but they, from my perspective, they could have been moving a little bit faster, I would think. And certainly, importantly, also going beyond the DRI, all of us, there's disparities in clinical management of type 1 diabetes that probably bother most of us. It's tricky business, and it's in its origin multifactorial, not only in other countries, but certainly also in the US, as many of you know. And that's really a difficult area, but all of us, including myself, we should try to do our best to be active there. So we don't have HbA1cs or COVID death across a socioeconomic divide. It's tough. Well, that can be tough.
I think we have another question in the chat from Mindy Gross.
I actually have two. So from I have one from Michael Myers and I have one from Mindy. Mindy, did you want to ask or did you want me to read it?
Yeah, so my question is, like, with the monoclonal antibodies, when it became, with the COVID vaccine, they talked about it potentially being a cure for different diseases. Is that one of the areas that you think is going to be pursued for diabetes?
I think there are monoclonal antibodies beyond anti-CD3. That is a very good question where we can learn from other diseases. We have to do it cautiously because not everything that might work in arthritis or lupus or alopecia might work in type 1 diabetes, but we can test it. And once we test it, some of the drugs that exist in other settings might also be very good for type 1 diabetes. In some cases, we can also learn from other disease applications. So if you, for example, take an antibody like the anti-CD40 ligand that the DRI is intensively working on, it seems to work in transplantation, in kidney transplantation. There's good data now. So this cross-fertilization is very important. It's often also underserved by the pharma industry because they're more focused on a specific project. So I think there we can learn and bring new reagents in that will be very useful for type 1 diabetes. Also in the area of antigenic tolerance, where we can learn from other diseases such as celiac disease and so forth, because they all have their different facets, and sometimes the targeted organ, like in celiac, the gut, is more readily accessible than the pancreas. So we need to learn from that. And a lot of it can happen actually at the university in collaboration with different departments. It's very good. Sorry, you had a second question. Now I don't remember it.
Oh, I think John Carrion's raised his hand. Why don't we hear from John, if you don't mind? Go ahead, John.
Hey, guys. Yeah, I'm going to put you on the spot for all the people who from the, with loved ones that have type 1. What's the next breakthrough? Where's the next breakthrough going to come through? We've had some great news with Vertex and being able to delay onset of type 1. What's the next big breakthrough that you feel and time frame? I'm putting you on the spot.
Time frame is always uncertain because as much as we cannot predict individually when anybody gets diabetes, because it's sort of a complex process like a climate change, I'm always reluctant to give a clear time frame. I can give you the idea of the events we eagerly await that will define the field. We will learn from the Vertex device trial. That will be an important readout. If it goes badly, it delays things because it knows that sort of you try to your first transatlantic flight and you have an emergency landing about 200 yards out behind New York. That's not so good, or it goes really far. So we have to see how that goes. That could define a lot of things, what still needs or not needs to be done in the field, and we will see. In terms of basic discovery, I'm very excited about our organoid approach and finding the priority, what works best to protect the beta cells. I think this can be a tremendous accelerator, and we just working very intensively now to get this off the ground. I think that will be a defining event in the field. And if I had my way, I would like to see a combination trial between a beta cell protector and an antigenic tolerance. That has been a lifetime wish of myself. And it would have to be a full-scale trial, but they read out after 5-6 years. They take long if you do them. So these are some of the things I'm super excited about, that I feel are in the proximal future and can give us building blocks that are vital to better see how far we are from the final solution. This is going to be like an incremental step type of situation in all likelihood. It's not going to be binary, unless we get very lucky. It's not going to be binary that there's no cure, then it goes poof, and all of a sudden there's a cure. The more likely scenario is like in oncology, you do it like this, but you arrive at the same finishing line. Of course, we take that. It goes like this. Anybody will take that, so.
Michael, it looks like you had a question about collaborations outside of diabetes.
Yeah, I just wanted to build on Michael's question, and obviously one of your favorite topics, Dr. von Herrath, about collaboration. But can you see advantages to forming strategic collaborations outside the diabetes community, particularly in research?
I think if we have sufficient funds, yes. It has always been my wish to learn more across diseases. In the older days, 12 years ago, we had these groups at the Federation of Clinical Immunology Societies where we would learn from MS and arthritis and alopecia and bring groups together. We still have this in our pathology meetings where we learn the pathology of type 1 and realize it's so similar to alopecia as a disease of spotty hair loss, can be total hair loss. And the pathology is surprisingly similar between the two things. So it behooves as well to cross-learn as much as we can. And that's the easy part. The tricky part is to get these things implemented, because you have to sometimes bring whole associations together. You can't just take the DRI and all of a sudden you fundraise for alopecia. Then it would be better to do it together as a joint project with the NAS Society for alopecia, and then bring the investigations together like this. But we should do more of it. And I mentioned in the pharma industry, it hasn't been easy. We have to do more of this. We have to look in other diseases, learn from alopecia, see whether a drug can work if you put it under the skin, see what it does, and then extrapolate from that what it might do in the pancreas. It gives us human learnings. So it is important, and it's probably somewhat underserved for that reason. We have started good collaborations in with the oncologists and various other institutes to cross-learn in important areas.
Thank you.
Sarah, any questions in chat?
I do. I have one from Charlie and one from Larry. If you guys both want to ask, or I can read them aloud. It's up to you. Oh, Charlie, want me to read? Okay. Charlie asked that he just said that he searched for advocacy link or a section on the DRI website. Is there a formal DRI/DRIF advocacy group or team? He's been involved with JDRF advocacy, and he would be glad to add his voice to the DRI/DRIF advocacy efforts.
I think we have done some of that. Some of you might speak better to this than I can do. I think we should do more. I would love that to see it evolve, and I would like as many of you as can be involved in this if you have the reach. That would be fundamentally important, as well as for regulators. Some of it for awareness. It can be tremendously helpful. I know Tom has for sure done a lot from the patient side. It's needed. We sometimes get quite interesting remarks, I should say. I had this recently at an advisory board. One endocrinologist said he could just tell type 1 from type 2 diabetes by looking at the patient. That was a curious remark to me, because that's not how it works. So that was an interesting situation. And we had in the art board for anti-CD3, I mean, it was not our output, but we listened in. There were many who said, anti-CD3 for type 1 diabetes, we don't see the need and we don't see this disease really as a problem because we just take the insulin, gonna be fine. So yes, we need advocacy. That would certainly be something I would love to grow together with many of you.
And I think that this is absolutely something the foundation will be focused on going forward. We have on this call some people who bring just a tremendous amount of passion and talent and a sense of urgency to this issue of advocacy. And Bob, I'm looking at you, I'm looking at others, of course. Yes, this is something that I think the foundation will certainly look at and take a run at, I think, at formalizing our work here. I think we've done a lot of good work in advocacy over the years, but not necessarily in a formal, focused way. And I think there's an opportunity for us there.
Mike, can you hear me? It's Charlie.
Yes.
I just forgot. I have a huge microphone that's not plugged in. I forgot to have a mic on this. Going back to the Matthias had said something about the CDC and others did not think that there was a problem after all we have insulin. My son was diagnosed 50 years ago, this coming January, and he passed away 2 years ago. The significance of his diagnosis at 23 months. I did some research and I found the testimony for the United States Congress. I forget what committee on the impact of type 1 diabetes or juvenile diabetes at the time. And they said that the lifespan, expected lifespan for somebody diagnosed as an infant was 25 years. So he was pushing 2. I did the math. That was 27. I was 27 at the time. And I just was, floored at the thought of my son not living as long as I had already lived. A few years after that, my daughter was diagnosed at 25 years. And she is having some other complications. Been a volunteer for JUF since 1975. My wife and I formed a local chapter. So I'm a staunch JDRFer, but I'm a staunch outspeaker, if that's the right term, for our cause for any organization, especially DRI. I had the opportunity to take a tour of the labs probably 25 years ago, met Dr. Riccardi and Dr. Norma, I forgot her last name. And my wife and I walked outside at the end of the tour. I sat on the curb and I started crying. My wife said, "What's the matter?" I said, "I just met the people who are going to cure our children. It's come too late for my son, but I hope it doesn't come too late for my daughter." So I don't want to hog the meeting, but there are a lot of us out here who, we do our advocacy for legislative efforts. If you ever need somebody to write a letter, you do an email or get involved with the DRI efforts as well. I can do both. It's the same topic. It's the same cause. I don't care what T-shirt we wear. Sarah, you have my email, right? Just reach out to me if there's anything that you need me to write an email for.
I think we progressed to it being
so sorry to hear your story, and it will make us work even harder. I mean, we need to solve this. And
I know you guys are working hard. I actually got into a fight with my minister shortly after that visit, as I was on a letter writing campaign, letters to the editor, and the minister in his sermon made some kind of a off the cuff remark about scientists, researchers who were using stem cells, and committing acts of atrocities, like they're committing crimes. And I got him out of church. I said, I talked to a mother who happens to be a researcher, and she was crying, talking to us. These are not people who are just trying to suck the money out of the system. These are, like you said, your story of trying to attract young minds, young researchers into the business, if you will, of diabetes research. We have to not only raise the money, but get the people who those who have the wherewithal and the training, or decide which direction to be trained in, to understand the significance of the contributions that they can make, and hopefully still pay their bills and raise their family. So
and that's so important what you say. There's many ways to ethically, obviously, work with stem cells, and it should not be limited. And sometimes I personally think this issue that people tend to say that a problem is solved that evidently is not solved, or it shouldn't be for a patient that evidently is a huge problem for a patient. I think it comes out of a human intrinsic wish to have solutions to things. We saw some of this when we had the COVID pandemic. There was maybe a little bit of too much of a narrative for my flavor, saying, oh, we got this covered, this is all under control. And some things were really good and some things were really not under control. We have to have the humility, the advocacy to realize what we can and cannot do, and where it's needed, and where the problems really are for the patients.
I think if it was solved or under control sufficiently, I know for sure there's a lot of faces on the screen right now who would be, they got other things to do. And one of them, I was so happy to see Tom Carlisle. I don't know if Tom remembers me, but I remember Tom being a MC, or whatever the term was, at the JDF as it was back then, conference. And then he got involved with DRI. I know Bob's been riding his bike for a while, raising money for research. So, and I don't know the recipe here, but I sense that dedication. And if we can harness that dedication, not just of who's here, but to recruit and do a form, if it's a thing that contributes to the strategy of DRI, to do some advocacy. And I use that term very loosely. It doesn't have to just be legislation. If it's writing to pharma, if it's writing a thank you letter to researchers, thank you.
It could even be as simple as putting posters up in the neighborhood. Really, as simple as it's a whole site where you can download just posters for awareness, so people aren't dying at diagnosis. So the wonderful thing about advocacy is that it's so large and so wide. And my saying has always been, just don't do nothing. If you're doing nothing, then nothing will get done. So
others will say they can't do enough, but you don't have to do it all. Do your little smidgen. Everybody does their smidgen. The room is full. I'll shut up now. Thank you for your efforts.
Thank you, Charlie. Thank you for sharing your story. And it's just a reminder of, how high the stakes are here, how high the stakes are. And I know that we have one more question in chat, and it's Larry's question, and it's a really good one. Larry, I'll just go ahead and read it if that's okay, unless you'd like to.
Oh, you can read it. Sure.
Larry asked about the role of AI in as a contributor to progress to the cure. Could you speak to that, Matthias?
There you get my favorite topic, Larry. Yes, I was at the biomarker conference this morning. We were discussing it before the meeting here started. And I think some of the AI approaches are now ready for prime time. I wouldn't have thought it happens so fast. I'm particularly intrigued by some of these more unprogrammed, pre-programmed, more free-flowing approaches. We all have seen what the chat GPTs can do and cannot do, fair enough. We have used AI in image analysis in pathology. And you can give the AI tasks to do that we wouldn't do as humans, just instructively, and you learn a lot, like how many cells have been in contact at the murder scene of the islet over time, and where did they go and stuff, because we can't quantitate all this. These type of questions teach you a lot. But you can also have unbiased algorithms evolving in AI, and unbiased, unpreformed algorithms are very interesting. This morning at the biomarker conference where I gave a talk, there was a lot of companies who have been starting to use this. And the interesting thing is these computer minds, they come up with stuff you can't predict. Sometimes you don't even know what it is that they use to discern A from B or predict C from D and E. You don't know, but it gives you actually new research tools to then dig deep and understand this. So for me, it's an extremely fascinating field. I cannot see progress without AI. If you would ask, what is the biggest, let's say, threat of replacement for our grandiose organoid strategy? Interestingly, I talked to a guy yesterday at lunch who has an AI company, and he said, well, let me see what I can do if we work together. We have all these pathway analysis, and we have been pretty good at predicting which pathways are the major ones, the minor ones, the nodal points where things go through. And I think it's it has come to a point, it's so good that you're not getting weird answers, but you gonna get really instructive things. Sort of like like ChatGPT as a language program. The early stages when you looked at these things, you would go like, really? You're suggesting this word on my iPhone to put in this email? You gotta be kidding me. Where's this program coming from? Now these things become pretty helpful and interesting. Not free for all, need supervision, but it can be very, very good. So I think it's a tremendous driver. If any of you has links to the AI field, that can tremendously cross-fertilize. For example, we used to have a collaboration for this histopathology image recognition from those people who were writing image algorithm apps for the iPhone, so that would recognize which pictures you are in and which your grandchildren or the children and the spouse and so forth. So I think things have come a tremendously long way there, and I get the feeling that also in that field, the advance is now more quantum leaps than incremental. It's pretty cool in my mind. There's probably many people who disagree. Usually when I discuss it at home, my wife disagrees with it, but that's more because I like to watch movies of humanoid robots and stuff like that, and I understand that's maybe an acquired taste that not everybody will be watching.
Well, this has been a great discussion, and Matthias, thank you so much for joining us this evening.